I'd like to welcome everybody to this session on health workers in conflict zones. We have a terrific panel this morning, and I'd like to just give it a little context. By the way, my name is Len Rubenstein. I'm at the Bloomberg School of Public Health at Johns Hopkins, and I also chair the Safeguarding Health in Conflict Coalition, which I'll talk about at the very end, about our upcoming report that we'll be putting out in a few weeks. This issue of the security of health workers and health facilities in conflict zones was not on the international agenda at all 5 years ago. It was not the subject of conferences. It wasn't the subject of discussion. It wasn't on the agenda of any UN agency. But in the last 5 years, it has become part of the agenda of WHO. We had a resolution last year from the UN Security Council. The UN General Assembly has acted. And yet, in those 5 years, although we don't have really good data to determine trends, the situation certainly hasn't gotten any better and may have gotten worse. Certainly in Syria, we know it got worse. So we're here today to talk about the problem. We'll have a discussion of documentation, we'll have a discussion of country situations, and we'll have a discussion of the global picture and what can be done, including what the academic community can do. So I want to start right away. We have 4 great speakers, and our first one is Christine Monahan, who has a PhD in International Relations and Refugee Education from UVA, and she is a researcher at Watchlist, an NGO in New York which focuses on protection of children in armed conflict. And she previously served at the Global Coalition to Protect Education from Attack and was instrumental in a report it issued in 2008. And she's carried out many field investigations in sub-Saharan Africa and taught courses in international education at University of Virginia and NYU. Chrissy, take it away. Do you want to sit here or at the?
I can stand. That'll be fine. Okay, great. Well, thank you very much, everyone, for being here today. Let me get it slightly adjusted here with the mic. Okay. So what I'm going to speak about today are 2 reports that one we have launched, the second we are about to launch in 2 weeks, focused on the impact on children of attacks on medical facilities and personnel in Afghanistan and Yemen. And what you're looking at there are the titles of the 2 reports. The Afghanistan report, Every Clinic is Now on the Front Line, and the Yemen report, Every Day Things Are Getting Worse. I'm going to focus first on the Afghanistan report, and then in the tail end of the presentation, I will talk a bit about the Yemen report as well. And when we look at Afghanistan, what I want to do is start with the numbers. So between 2015 and 2016, the UN documented more than 240 attacks against medical facilities and personnel in at least 20 provinces throughout Afghanistan. Though different in the type of attack and direct impact of attacks, that figure is on par with the number of UN documented attacks against healthcare in Syria carried out during the same period of time. The majority of attacks were perpetrated by armed opposition groups, the Taliban and ISIL-KP. However, Afghan government forces, including the local police, national police, army, special forces, and the Directorate of Security, carried out about 20% of the incidents during that reporting period. There have also been some incidents perpetrated by international military coalition forces, including, as is well known, the bombing of MSF's trauma center in Kunduz in 2015. When we look at types of attacks, threats, intimidation, extortion, detention, or killing of medical personnel constitute the majority in Afghanistan, about 80%. There were also several instances that we found of the forced temporary or permanent closure of medical facilities. Many facilities were directly or indirectly damaged or destroyed by mortar rounds, IEDs, shelling, and airstrikes, particularly when the line of active conflict was close to the facility. Parties to the conflict also occupied facilities for varying lengths of time, using them as barracks and as strategic positions, Medical facilities and supplies were often damaged when this occurred, and vaccines and medicines were looted by the occupiers in some cases. So when we look at research methods and capturing impacts of over time, it's difficult to distinguish between the impact that armed conflict itself has on health impacts from the impact caused by attacks on medical facilities and personnel. So we don't claim to capture causally the impact of attacks on health facilities and personnel on children, but we want to show a correlation. So what we did was we first conducted a systematic review of UN and non-UN organizations' reports related to attacks on healthcare, as well as public health and the delivery of humanitarian aid. So this included OSHA humanitarian bulletins, weekly epidemiological reports, and health cluster meeting minutes. I also conducted field research in Afghanistan late last year, and research for the report was carried out in 5 provinces: Herat, Helmand, Kabul, Kunduz, and Nangarhar. Overall, we spoke with about 80 people, including medical personnel, humanitarian staff, government health professionals, parents of children impacted by attacks, and children themselves. We conducted 5 on-site visits to medical facilities in 3 of the provinces visited. So, as I mentioned, there are some challenges capturing impact. What we do is we try to set up the pre-conflict health context. So looking at where indicators stood in 2014, showing how as conflict escalated throughout Afghanistan during 2015 and 2016, attacks have compounded known health challenges. And then we also focused on 4 focus provinces within sections of the report and showed, focusing on Kunduz, Nangarhar, Wardak, and Helmand, how specific incidents and impacts affected populations there. I want to spend a little bit of time focusing on the pre-2015 health context in Afghanistan because it's so significant to what's happening now. Since 2001, USAID, the European Union, and the World Bank have collectively invested more than $1 billion to strengthen and rebuild Afghanistan's healthcare system. Hundreds of clinics and hospitals have been constructed, and thousands of staff have been trained through a system of implementing partner INGOs and NGOs. 1 or more NGOs will be responsible for healthcare in each of Afghanistan's 34 provinces. And when we think of it in this way, INGOs and NGOs are both literally and figuratively on the front lines in Afghanistan. Despite significant growth in the healthcare sector, at the end of 2014, many Afghans struggled to access healthcare. About 1/3 had little or no access. About 40% of children under 5 were stunted due to chronic malnutrition. And despite significant gains made through vaccination campaigns, there were several cases of polio and other preventable diseases. During the reporting period, as conflict has expanded across Afghanistan and the intensity of conflict has sharply escalated, about 30% of the country is currently contested by government forces and armed opposition groups. In these areas where there has been heavy fighting, civilians' needs for healthcare have risen, while their access to healthcare has sharply contracted. So, for example, UNAMA documented a 24% increase in child casualties in 2016 compared with 2015. There has been a 40% increase from the start to the end of the reporting period in numbers of children suffering from malnutrition. And in 2015, there was a 141% increase in measles outbreaks compared with 2014. Attacks have compounded these and other challenges, as humanitarian organizations have temporarily and in some cases permanently suspended their operations. Many medical personnel have fled areas of conflict, and those who remain have expressed fear that they will be injured for doing their jobs. Due to the flight of personnel and challenges hiring new personnel, many staff with limited training are treating complicated trauma cases. And because of threats and intimidation against INGO and NGO implementing partners, there are often delays delivering supplies, which means essential medicines and materials to treat basic trauma cases haven't in some cases been available when needed, and staff have had to improvise. What I'd like to now do is share with you some of the incidents and case studies documented in the report in 2 out of the 4 focus provinces. In Nangarhar in 2015, ISIL KP reportedly closed 10 medical facilities in some of the districts it controlled as part of an anti-vaccination campaign. On December 25, 2016, the Taliban abducted a doctor from his home and then killed him for reportedly refusing to treat Taliban troops. A vaccinator told Watchlist, "With the coming of ISIS, new problems have risen. I have seen with my own eyes in an area of 100 meters there are 3 kinds of leaders: Taliban, ISIS, and government. All over, vaccinators face more problems than any other medical personnel because we have to travel and go inside these villages full of Taliban and ISIS. So even though it is my job, I had to stop. Otherwise, I thought ISIS or the Taliban would kill me." In Wardak, on January 11, 2016, between 60 and 70 Afghan security forces entered and searched a hospital in the capital city, Maidan Shar. They interrogated medical personnel about persons treated the previous evening and warned them not to provide services to any insurgents. On February 12, 2016, members of the Afghan National Army occupied a medical facility for 2 days, and during that time looted and destroyed medical equipment and medicines. According to the Swedish Committee for Afghanistan, the NGO that runs the facility, the number of patients seeking treatment at the hospital decreased by 67% in the 10 days following the attack compared to 10 days before the attack. These examples I just mentioned are part of the approximately 50 incidents documented in the report and make clear that in Afghanistan, medical facilities and personnel are being attacked as a tactic of war and that children's right to health care are being violated as a result. I'll now turn briefly to Yemen, to a report that we're just finalizing now, and provide an overview of that report and excerpts from some of the case studies. Between 2015 and 2016, the ICRC has reported that at least 160 attacks have been carried out against medical facilities and personnel by the Saudi Arabia-led coalition, the Houthis, and forces aligned with the government in exile. The Saudi Arabia-led coalition has in numerous incidents bombed hospitals through airstrikes, sometimes hitting the same facility repeatedly. In some incidents, the coalition has launched double and even triple tap strikes designed to hit the same area when medical personnel arrive to treat wounded from the first strike. The Houthis and forces aligned with the government in exile have threatened, intimidated, detained, abducted, and killed medical personnel and denied passage at checkpoints to humanitarian workers and patients in need of critical care. There have also been many documented cases of the occupation of medical facilities by parties to the conflict. Additionally, a de facto blockade imposed by the Saudi Arabia-led coalition since 2015 has restricted the import of food as well as supplies necessary to run medical facilities. And this includes medicines and fuel. Why this is so significant is that prior to the conflict, Yemen imported 90% of its food, 90% of its medicine, and 70% of its fuel. So the impacts on the health of the population and the health sector have been devastating. As of January 17, almost 2 years into the conflict, only 45% of medical facilities are functioning. Almost 15 million Yemenis lack access to basic or adequate health care. More than 18 million Yemenis are in need of humanitarian aid. That's almost 70% of Yemen's total population. And since March 2015, there has been a significant increase in the number of children injured by the conflict or suffering from preventable diseases, including acute respiratory infections and diarrheal disease. As with Afghanistan, however, despite these increasing needs, children's access to resources needed to treat them, partially due to targeted attacks on medical facilities and personnel and the de facto blockade, have dropped dramatically. According to UNICEF, in a recent figure published, approximately every 10 minutes, a child in Yemen dies of preventable causes, such as malnutrition, diarrhea, and respiratory tract infections. I'll just now share 2 excerpts from case studies. The first from a humanitarian aid worker we spoke with, who describes how the blockade has impacted the healthcare sector. He said there was very little access to public health care before the war. Now there is essentially no access. It's because of attacks on civilian infrastructure. For example, bombing the electricity plant early on so that all hospitals and primary healthcare centers were running on generators. But there's an extremely limited amount of fuel, so a large number of facilities have to close. If you need trauma care, it's hard to access treatment, but there's probably a better chance you will be treated than if you need chronic or routine care. Dialysis, cancer treatment, it's almost impossible to get help for these issues anywhere in the country. But all of this is also because of the targeting of medical infrastructure. It's a reality that happens every day, and healthcare workers are at great risk. For example, there was a double tap on the hospital in Sada. They bombed the hospital, and then waited until health workers started responding, then they bombed again. It's a tactic to terrify the population. We also spoke with doctors who described challenges they face in continuing to work amid conflict and insecurity. One doctor said, "The past year has been the worst year of my career. We have been working in an extremely insecure environment here, as the hospital is located very close to areas targeted by airstrikes. We have been forced to stay in the hospital when airstrikes have been hitting the surrounding area to keep providing health care to patients who need our help the most, especially babies and children." And another doctor said, "We are afraid all the time. The hospital is close to buildings that are being targeted by coalition airstrikes. Almost all the windows have been destroyed by bombs." In terms of recommendations, in both reports, we're calling for better data collection of attacks, the end of impunity and improved accountability in international and national courts for perpetrators of attacks, and better training in international humanitarian law, particularly on the protected status of medical facilities and personnel for armed forces and groups. The note I'll end on is that I was just in Afghanistan last week for a series of meetings regarding taking recommendations in the Afghanistan report forward. And in that case, there are just a few promising indicators, but that's something to focus on. In terms of data collection, the health cluster there is setting up and systematizing a data collection system in cooperation with the Ministry of Public Health and led by the World Health Organization. And they're doing this with the idea that the Ministry of Public Health can more regularly engage with the Ministry of Defense and Ministry of the Interior to ensure that investigations are undertaken, particularly on incidents believed to be perpetrated by Afghan armed forces. With regards to Yemen, in terms of taking forward the recommendations, it's undoubtedly going to remain challenging. But nevertheless, we'll see what comes about with the report's release and other activities around it. And I'll stop there. Thank you.
Thank you, Chrissy. And now we'll turn to Syria. And we're very privileged to have Dr. Zahir Salul, who is past president of the Syrian American Medical Society, which many of you may know has become not only one of the leading humanitarian providers for healthcare in Syria, but one of the leading advocates for protection of the Syrian people. Dr. Salul has made innumerable trips to Syria to support physicians there and been a tireless advocate for the Syrian people at the highest levels of government in the UN. He's the recipient of many, many awards, most recently the Robert Kirshner Award for Global Activism from the Marjorie Kohler Center in Chicago.
Thank you very much, and I'm really honored to be here, and I'm going to shed some light on the difficult situation that is happening in Syria. I'm not going to focus that much about the numbers, but I'll focus on stories and reflections and how the medical community in Syria, with the help of the Syrian American and Syrian diaspora in general, is able to deal with the attack on healthcare. And I can tell you that I'm a critical care specialist practicing in Chicago. I never imagined that I'm going to be talking about attacks on healthcare in my homeland. And I don't want to be in that position. No physician should be put in a situation that talks about attacks on healthcare. Should not be accepted. And the fact that we are talking about it as it is a normal thing is not normal. So the normalization of attacks on healthcare is happening in front of our eyes, academics and physicians. And this should not be accepted. The same thing that normalization of the use of chemical weapons should not be accepted. This is from my last trip to the city of Ma'arat al-Nu'man in northwest of Syria, not far from the site of the chemical weapon attack in Khan Sheikhoun, just a few kilometers away. And this is a tertiary center. This is the largest public hospital in Ma'arat al-Nu'man, supported by the Syrian American Medical Society. And I was there when we had this jet flying above our heads, and people were pointing to it, and they were saying this is a Russian jet. And I said, how can you differentiate between Russian and Syrian? They said, we've been here for 6 years, and we know how to differentiate between Russian and the Syrians and the type of missiles and all of these things. Anyway, we went into the basement of the building, and fortunately, they did not bomb the hospital that day. This is the hospital from the inside. This is a child that I saw in the ICU who was struggling to breathe. We had to intubate him, put him on the ventilator. The unique about this ICU that is connected to United States through telemedicine. So I took this picture from my iPhone. I have this application called Smart Camera that I can look at hospitals inside Syria and difficult to reach Syria. And then I can zoom at the patients with the help of the physicians over there. So I was there and I zoomed at myself and I took this picture from my iPhone. Of course, that went to the satellite, then back. And we had this facilities, the telemedicine, in several hospitals in Syria to deal with this situation, which is attacks on healthcare, because we want to make sure there's shortage of physicians. And the only way to reach these physicians inside Syria and provide advice 24 hours is by using these tools of technology and communication that are available. This is Dr. Ali Darwish. And every time I do this presentation, I have to update it with numbers and update it with pictures. And these are very unfortunate pictures. This is a surgeon, the only surgeon in town in a city called Al-Latamina, north of Hama. He was doing surgery in a field hospital on a patient when his hospital was attacked with chlorine gas. And he continued to do the surgery. He inhaled large concentration of chlorine. He developed pulmonary edema. They took him to a tertiary center 2 hours away, and he died in the road. The hospital that I told you about, Ma'arat al-Nu'man, after the death of Dr. Ali Darwish, which happened last week, they sent us a few days after that, on Sunday actually, that they are receiving patients who are having shortness of breath and foaming, and they have pinpoint pupils. That was last week. That was on Sunday. And they sent us this information on WhatsApp. This is the way that we communicate with that group, that we have this patient, and this is his monitor, and they send also information about the patient. That's the way our doctors communicate with them. For those who speak Arabic or read Arabic, it says that we have a 19-year-old person who is exposed to chlorine gas. He had some shortness of breath and cough, and this is his vital signs. And then Dr. Anas Mughrabiya, who's an ICU specialist in Michigan, sent them some protocol on how to deal with this patient. And this is another patient they sent the same day, 30 years old, more sick, who had severe shortness of breath. He had cough with sputum production. He was tachycardic. His oxygen level was 53%. Normal is 100%. And he was tubed and placed on mechanical ventilation. This is his mechanical ventilation monitor, and this is his monitor. And this is his X-ray that was sent through WhatsApp. And this is his lab, blood gases. And they send us also his video. I don't know how can I put the video, the left one. And this is his eye.
هذا أحد الإصابات الذي قدمت إلينا. إصاب
بالتسمم
مع تقبض حلقات.
The doctor took his video of the patient because he thought that this is something that is not typical for chlorine exposure.
حتى الآن من أمبولات أتروبين ولا بتمسح حلقات.
More typical of exposure to nerve gas, not chlorine exposure. So what we did with this video and the pictures that we posted it online, we did a small report. We shared it with the State Department because it's not normal to have people exposed to nerve gas, even in Syria. Chlorine has been used frequently, but nerve gas since Ghouta 2013. This is the first case of nerve gas exposure. It looks like nerve gas. And then we also informed them what to do with the samples and how to collect samples, and so we can confirm what type of chemical agent has been used. And this is the way that doctors and nurses protect themselves from exposure to chemical weapon. They do not have the right protective gear that is needed to protect themselves. So not only they are bombed, but also they are bombed with chemical weapons, and they do not have enough protection to protect themselves. This is the patient after he was extubated. He survived the attack. That's on Sunday. The hospital on the same day was bombed, the same hospital. Sunday, that was 5 days ago. And it's the largest hospital in the region. It's a tertiary center. It serves 13,000 patients every month. So this hospital that is connected to the United States, that is treating many victims of not only chemical attacks and injuries, but also treats patients who have chest pain, pulmonary embolism, infections. It has a birth center, it has a neonatology center, it has a dialysis center, is out of service for the past 5 days. And when we talk about displacement of the Syrian people and the fact that we have 5 million refugees leave when there is no hospitals in town, when there is no doctors in town. Dr. Al-Muaz, one of the last pediatrician in Aleppo, he said that we are the last hope in the city. When we go, life stops. And as you know, you've seen some of these pictures. I'm not going to put this video. It's very painful. This is a video that we've seen on Tuesday of children who were struggling to breathe, many of them dead because of the Khan Sheikhoun gas massacre, also with the nerve gas. Some of these victims would have been survived if this hospital in Ma'arat Nu'man is open, because they have the facility to intubate and put on life support. But because it was taken a few days ago, then these patients had to sometimes take long distance to be transferred to tertiary center, to the Turkish hospitals, and many of them died, 84 so far. This is Dr. Wasim Al-Ma'az, one of the last pediatrician in East Aleppo. And he was killed sometimes in April of last year. When you have no pediatrician in the city, imagine what will happen to the population of the city. I went to Aleppo several times. Last time was July. In reaction to the killing of Dr. Al-Ma'az, I had with me two physicians from Chicago. One of them is Dr. John Kaler, who's a pediatrician also. And he said he wanted to go there because he wanted to help the children of Aleppo. But I asked people, what keeps you in the city? There were 250,000 people at that time. And they told us, well, this is our city. We had a population of 1.5 million before the crisis. Right now it's 250,000. And as long as we have schools and we have doctors who can treat our children, we'll stay. And they can take the bombing and they can take the risk of being killed. But they had what they thought it is a part of normal life. When doctors are killed, people leave. This is one of the chaotic scenes that you see in the emergency room in eastern Aleppo at the peak of the bombing. And imagine that this is happening every day, and you're a physician. We talk about attacks on healthcare, physical attacks, but imagine the attacks on the psyche and the emotional status of doctors and nurses that they are dealing with the situation day after day. Most patients, most doctors in Syria have post-traumatic stress disorders. Most of us who go back and forth into medical missions have some type of psychiatric problem because of what we are seeing. And these things are not addressed. We talk about the psychiatric issues and the post-traumatic stress disorder on children, on elderly, but we do not talk about how to deal with these problems within the medical community. This is one of the hospitals that was bombed in Syria, and this is Dr. Sam Al-Attar, Dr. John Kaler, who accompanied me in the city of Aleppo. I think all of us know why should we care about Syria. What's puzzling to me that the president of Syria is a physician. He graduated from medical school, and he had 2 years of training as an eye physician in United Kingdom. He was my classmate, and this is one of the meetings that we had with him a few years ago, 1 year after he became a president. He told us that he would love to be a doctor, not a president. No one believed him, of course. Syria was a middle-income country with good healthcare benchmarks. It had very high vaccination rate, 99%. We had no polio for 15 years before the crisis. We had the transition that you expect developing country to have from infectious disease or mortality related to infectious disease to mortality related to NCDs with heart diseases and hypertension and diabetes. We had an epidemic of obesity like what we have here. And we have very high smoking rates in Syria. 70% of men smoke in Syria, one of the highest smoking rates in the region. The average life expectancy in Syria before the crisis in 2011 was 76 years. Not bad for a developing country. It was 56 years in 1970. Right now, after 6 years of the crisis, it went back to 56 years. Sometimes we like to look at these conflicts as simple conflicts, that you have civil war or you have terrorist organizations fighting the government or government fighting the people and so forth. It's a little bit more complicated than that. And if you are interested, we can spend the 2 hours talking about the factors that led to the civil war in Syria. It's usually complicated. That's why the civil war lasts for a long time. And that's why the average time for civil war lasts for 25 years or so nowadays. Even if the crisis in Syria stopped right now, it's going to take 25 years for the refugees to go back to Syria, if ever. And Syria right now is divided. We have the image that Syria is one country and that NGOs have access to all the country. United Nations have access to the whole country. It is not the case. We have parts that are controlled by the government, the beneficial Syria as they call it. We have parts that are controlled by the rebels, moderate rebels. And we have parts that are controlled by ISIS. Their capital is Raqqa. And we have parts that are controlled by Kurdish group. So there are at least 4 or 5 zones in Syria. Each one of them has different healthcare system and healthcare deficiencies and the challenges in reaching to these areas. So that's very important to understand when we talk about a country in a conflict. Every time we use a new figure in relation to the Syrian crisis, we say it is unprecedented. This is Valerie Amos. She said it a couple of years ago. And I have to update these numbers. And I can talk about the 500,000 people who are killed and the 5 million who are refugees and 12 million who are internally displaced and the 13 million who are in need and for emergency assistance and the 600,000 who are under siege. But these numbers do not mean anything. Do not mean anything. I think what we need to look and focus more are the pictures and the stories and the people. And this is a picture drawn by students who's 2nd grade in Aleppo city. And you can look at this picture and that will give you really the whole story of the Syrian crisis. You're seeing helicopters that are dropping barrel bombs, and you're seeing houses on fire, and you're seeing children, instead of laughing and playing, they are crying. And you have dead children who are mutilated, whose heads are cut off. And what's amazing about this picture, every time I look at it, I cry, that the children who are alive, they're crying, and the children who are dead, they are smiling. This is some of the things that the doctors over there try to do to deal with the situation. You have sandbags, you have hospitals in the basements of buildings. This is an underground hospital, M10 hospital, that I spent my last medical mission in Aleppo, 20 meters underground. This is its ICU. They have these buses on top of the building to prevent the snipers from shooting to the people who are moving here. And this is the same hospital that was destroyed by a bunker buster. So they don't only use barrel bombs to destroy hospitals, but bunker busters. So no matter what you do in terms of protection, and I have this argument with my leadership in SAMS that they're insisting right now that we have to spend money on fortification and building hospitals in caves and building hospitals underground. I said there's no way that we can challenge people who have all of these weapons. No matter what you do, they can reach you and they can bomb your hospitals. So instead of focusing on building hospitals underground and in the heart of mountains, we have to focus on how to prevent attacking healthcare. And I think this is the challenge that we are all facing in the medical and academic community. And I really thank the leadership of Len Rubenstein, because this man, who's very humble, is the person behind that. We have some advocacy in the international community and the United Nations about attacks on healthcare. But I hope that after this presentation, each one of you will also be doing the same. Thank you very much.
Thank you, Zahir, for that illuminating and inspiring and disturbing presentation. We're now going to turn to Dr. Rohini Har to talk about some of the problems and challenges in documenting these attacks. Chrissy alluded to the difficulty of making connections between attacks and impacts, but at the global level, one of the problems this community faces is gaining credibility with UN and other institutions to prove that these attacks happened and who committed them. Dr. Har has worked on that problem. She's an emergency medicine physician and a research fellow at the Human Rights Center at the University of California at Berkeley. Her work focuses on the protection of human rights in complex emergencies, and she has worked in Haiti, Senegal, Ghana, Morocco, India, the Thai-Burma border, and elsewhere, and is a consultant to the International Rescue Committee and Physicians for Human Rights.
Thanks, Len. So I'm going to it's a little bit hard to follow Dr. Salul. I've done it a couple times now. But I think I'll focus a little bit on documenting these attacks and two of the projects that I've been working on. So I'll just mention that I first started working with Len in 2010, documenting attacks on health on the Thai-Burma border among groups in Burma. And what we were dealing with then was attacks that were considered chronic, right? So or small clinics being looted or health workers being arrested. And since 2010, a lot of things have changed. And in the past couple of years, most of the work that I've been doing has been in Syria, for the obvious reason that that's what's in the news and where some of the worst attacks are. But as Christine mentioned, the problem here is that the issue of attacks on health is far more widespread than what we see in the news. And even in Syria, where we see attacks and bombings of hospitals, it's much more widespread than that, because what we're missing is all the small stuff, the looting, the interrogation, threats against patients, blockages of hospitals. So I'd like to just make 3 points that hopefully by the end of this, the evidence that I have a little bit will prove. One, that attacks on health are both increasing and more widespread than what we think. 2, that good data is important. And 3, that maybe some of the new technologies that we have and that are being developed now can help. So, I'm sure this makes sense, but just to outline kind of the structure, it's obvious that bombing a hospital is bad and that, viscerally it's just terrible. But why? 1, you limit health service capacities. You break down health infrastructure. I know a lot of CUGH is dealing with health systems and health systems development. And, at best, develop a health system takes years and decades. And then to build one in a fragile context, post-war and post this kind of violence, takes much, much longer. And really something more insidious that is happening over time is fear of seeking healthcare services. So when you know that hospitals are being bombed, when you know that physicians are not there, that kind of fear can last far longer than it would take already to train medical students, build a hospital, have all the equipment. And really all of that leads to what we look at in public health all the time, which is increased morbidity and increased mortality. So I think we alluded to this already, but just to lay it out for you exactly what we mean when there's an attack on a hospital. It's not simply just a bomb falling on a hospital, right? So facilities and transports are like ambulances, but also trucks that are carrying medical equipment, vaccines, things like that. They can be bombed, but also that equipment can be confiscated. Checkpoints and delays can limit care. facilities can be bombed, but they can also be occupied. Supplies can be confiscated, and access can be blocked. Patients and healthcare workers, the two different kinds of people that are attacked in these conflicts, can both be shot, attacked, killed, but also interrogated, threatened, tortured, kidnapped, arrested. And in some of the early reports out of Syria, what we saw was that physicians were arrested and tortured, often for fulfilling their Hippocratic oath, really, for treating everybody. So right now, one of the major issues is that there's really no systematic or organized means of documenting all of these attacks. Why is that important? Because really, unless you document them, the Security Council and other governments won't act, right? So who's responsible? Is the UN responsible? Are governments responsible? Right now, most of this work is being done by NGOs and non-governmental organizations. So I'll focus a little bit about the work we're doing in Syria. So one of the projects that I'm working on very closely with Dr. Salul's team, it's the Syrian American Medical Society, and with our team at Johns Hopkins, is documenting these attacks on the field. So very briefly, what we have is data collectors who are on the field in Syria, and when they hear about an attack or when they find out about it, they go and they try to get some basic information. What we hope is that we have standardized information so that we can collect all of this and it's not haphazard. So they have phones with some of this documentation. They fill it out. They ask people on the field what happened. They look. They take photographs. And the value of this is because it's 2017 and we have media and we have phones and we have iPhones. This information is immediately uploaded onto the server. And so we can have real-time data analysis, which people on the field are using for advocacy and to help policy, and those of us here in the United States are using to try to create some sort of repository that could help potentially with accountability in the future, and also with trying to understand some of the risks and vulnerabilities that are going on. So, what do we have so far? Some of this data is very preliminary, but I thought it would be interesting. As Christine mentioned, there was about 100 attacks in Afghanistan, I think you said. So we at SAMS and Hopkins have documented about 113 attacks on health in 2016. Now, obviously, there's some overlap, but the vast majority, almost 100 attacks were on facilities. But you can see there's significant attacks on patients, personnel, and on transports as well. The location of the attacks, again, the vast majority is in different parts of Aleppo. So Aleppo's a city, but it's also like a governorate or a state. And so you can see that different parts of Aleppo have already been affected. But there's other cities. I should note that our project so far has only dealt with the 4 northern parts of Syria, Aleppo, Hama, Homs, and Idlib. And there's attacks in many other parts, and I think SAMS is expanding this work right now. Types of attacks. So again, this is very preliminary, but what we're mostly looking at is missile attacks and barrel bombs, and that was in 2016. So when we get this kind of information, it's really useful to be able to understand what's going on and how to prevent it. Another part of our project is to collaborate with other groups doing similar work. So we've worked with with Physicians for Human Rights, who many of you might have seen their map online documenting all the attacks. So one of the projects we've done is to compare every single attack line by line that we have documented with those at PHR to try to understand both what we're both capturing and, more importantly, what we're missing. So again, this is preliminary, but just between January and July 2016, you can see there's some overlap in what we're capturing, but there's also big parts that are missed. And so if we just do a quick capture-recapture analysis, we'd estimate that though SAMS has collected 79, Physicians for Human Rights has 44 that are verified. They have many more that that they've documented that haven't withstood the verification, that there could be as high as 114 attacks just in those 6 months alone. That's pretty powerful to think of all of the ones that we're missing and to understand why that is. So is it because nobody's there? Is it because just nobody's documenting them because there's so many? Is it because those are smaller attacks that we're just not seeing because, you know, people don't bother looking at looting when other hospitals are being bombed? And the third project that we've been working on recently is evaluating open source data. So open source is just publicly available data that's online and available to all of us. My colleague Sayaka Ree in the back will present this in a poster tomorrow with a lot more detail. However, what we looked at was understanding how attacks on health and other civilian infrastructure like hospitals, schools, and places of worship compare to civilian casualties. So as you all know, in most wars and historically, civilian casualties is how we look at the human cost of war. But these numbers are really hard to get and they're really dynamic. And sometimes documenting, you know, the destruction of a building is a lot easier in some ways to get photographic evidence and to look at it after the fact. Populations and people move around a lot, and it's a lot harder to document that. So if you compare, so as I mentioned, we used attacks on healthcare. We used data from Physicians for Human Rights, from Doctors Without Borders, and from the Syrian Network for Human Rights, which are all available online and all of you could reach it easily. For civilian casualties, we compared it against the Violations Documentation Committee. And finally, for the other attacks, we used the Syrian Network for Human Rights data. Again, these are all NGOs that are just doing it as best they can, and they all have different methods, but it's just a very preliminary way of looking at all the things that are happening there. So if you compare from all the different findings, schools, facilities, and places of worship are all being targeted. And you can see the trends are very similar. So when the bombings happen, they target all of these places. And then we compared civilian casualties with attacks on hospitals. And again, this is early on, and this is using open source data with different methodologies, so I'll put all of those limitations on what we have. But we're working in a context of war, and we're not going to get perfect data here. But if you look in the beginning of the war, you can see that there's some matchup between the number of civilian casualties month to month and how many hospitals have been bombed. You can see from about May 2014 onwards, there's a little bit of a split. So the red line, where you can see attacks on hospitals, kind of has a generally upward trend, whereas civilian casualties are kind of flattening out. Why is that? Is that because fewer people are dying? Potentially, but looking at what we say in the news, probably not. What we're probably looking at is a breakdown of infrastructure. So the people who count the dead, so, you know, coroners, medical examiners, people who count who lives and who dies are not there anymore. So there's nobody counting all of these dead. And two, there's a huge movement of people. So really it's impossible to count who's died and who's moved away. And so I would argue that this traditional use of using civilian casualties to mark how bad a war is, it has its weaknesses, and using other data like attacks on health could be useful in really understanding the human cost of war. The other thing I would say is, it's really interesting to think about, is that when we look at hospitals, as Dr. Salul says, when there's no doctors, people aren't going to live there. When there's no schools, no doctors, or no hospitals, and no places of worship, those communities aren't going to rebuild right away. People aren't going to flock back once the violence ends. So sometimes looking at infrastructure and civilian infrastructure destruction can mark not only what's happening now, but what's going to be happening for the next few decades. So as I mentioned, I'd really like to go back to my 3 points. One, that attacks on health are increasing. There's increased frequency of attacks on health in Syria and in Yemen, in Afghanistan, and in many other places. And we're just not capturing a lot of it because despite there being a UN Security Council mandate to do that, despite there being a WHO's mandate to do that, it's really hard to do, and it's just not working that well. Two, that this targeting has been systematic, and that the less accountability there is for that, and the less that people are brought to justice, the more that other actors and rogue actors are using this as a means of war. And finally, we're probably missing so many of the smaller attacks all over the world. Two, I'd like to say that good data is really important. So, sorry, these are a little bit cut off, but it's important to have a really strong analysis and an evaluation of the situation so that you can have better advocacy, so that when we say there's been gas attacks in Syria, that we have that data and something to back it up. And that there's evidence both in the short term for advocacy and policy change, but also that this is collected for potentially future accountability. And finally, for international actors to act, they really need solid evidence. And finally, there's new opportunities in technology. That second project I mentioned is all because basically of social media and being able to access things in real time online. And so you can really use what we have now in 2017 with social media, with mobile telephony systems, and with the web to get more information and faster and be able to use that. And then second, I think it's really, as a health worker myself, like it's hard enough to work in a hospital in the emergency room in the United States. I can't imagine what it might be like to work in Syria or Yemen right now. But I hope that some of the field documentation we do can really empower local health workers to be able to document what's happening to them and to empower them to use their knowledge and spread it. I think that's it. Thank you.
Thank you, Rohini. I'd now like to give you a bit of a global picture, both of the problem and the potential solutions. The picture you see, anybody know what that picture is? That was the Battle of Solferino. It was mid-late 19th century. And if you see on that picture, there were wounded people there. And it was a result of that battle that the International Committee of the Red Cross and the Geneva Convention started. Why am I showing you this? Because for 150 years, starting at this Battle of Solferino, the international community adopted laws that were ratified by almost every country in the world, saying healthcare is protected in conflict. You may not attack health workers, you may not. In those days, there was no bombing, but you could not shell health facilities. They gradually, the Geneva Conventions expanded from a concern here just to allow the wounded to be removed from the battlefield to protection of all civilians. And yet, 150 years, this is where we are. These are pictures from Syria. I don't need to talk too much about Syria. But there is a global picture. For the last 3 years, a coalition I chair, the Safeguarding Health in Conflict Coalition, which consists of about 30 humanitarian, human rights, professional, and academic institutions, puts out a report based on the data we have. We've heard this morning about how difficult it is to get good data on attacks on healthcare. It's underreported, and there's no systematic reporting. But what we try to do is to take whatever sources are available, UN agency reports, reliable NGO reports, reliable media reports, and find out what's happened in the world. And this chart is from our upcoming fourth report, which will come out later this month. And by the way, if you'd like us to notify you when it comes, I'll just put a sign-up sheet and we'll email you the link when it's available. And you see, as Rohini was explaining, there are many different aspects of interference and attacks on healthcare, not just bombing and shelling and torture of health workers, but occupation of health facilities, a blockage of humanitarian aid, blockage of ambulances, and you can see this actually has a few inaccuracies, so don't take a picture of it. It's still going to be changed. That there are 23 countries where we found evidence, and not only did we find some evidence, we found a lot of evidence where many different kinds of interference and attacks are taking place. This is a stunning problem. And you've heard about Syria, and I'm not going to dwell on Syria, but I think it is important just to look one slide. This is from the UN Health Cluster in Turkey. This happened during the time when the Syrian forces were attacking Aleppo. And if you look at the left side, you can see on the 28th of September, a hospital called M10 was subject to an airstrike. 3 days later, M10 was again subject to an airstrike. 2 days after that, M10 was subjected to an airstrike. And on the 14th, once again, 4 times in 2 weeks, this hospital was subject to an airstrike. And Physicians for Human Rights has documented more than 400 attacks on health facilities in Syria. So this is just a stunning problem. You've heard about Afghanistan, so I'll skip that. But there are other countries, just to give you a snapshot. In Iraq, what's happening is ISIS is taking over hospitals, in many cases evicting the patients, sometimes not, using it as a military installation or to treat its own fighters, abducting and killing health workers, putting bombs in ambulances. And in response, the government and its allied forces are conducting airstrikes against these hospitals. These hospitals still have patients in them. In South Sudan, which is an enormous humanitarian crisis, we have very poor data, but we know that last year in 2016, 16 aid workers were killed, health centers were shelled, bombed, and looted, patients were removed from hospitals, and medical care was obstructed. You never hear about this. Turkey, you hear even less about Turkey. There's an insurgency in southeast Turkey, and the government imposed a curfew in many cities, most notably in a town called Cizre. It closed 8 hospitals. Only 5 have been reopened, even though the curfew was ended. It took over hospitals for military purposes. It targeted and arrested health workers for providing treatment to the wounded and sick because these people are alleged to be enemies of the state. And the curfews led to the obstruction of ambulances, and at least 76 people have died. This is just in 2016. Occupied Palestinian territories, you don't hear much about that anymore since the war in Gaza a couple of years ago. But the Palestinian Red Crescent Society reported that there were 416 incidents in 2016 of obstruction of their ambulances by the Israeli Defense Forces and Israeli settlers, leading to injuries to more than 162 medics. 108 ambulances were damaged, and according to the Red Crescent Society, 146 incidents of denial of health care. And yet, for all of this, there's no accountability. As in our upcoming report, we look at 25 incidents of attacks on hospitals and healthcare in 10 countries over the last 3 years. And you can see the list of countries. It's a huge, major diversity of countries. And in some cases, some accountability proceedings have begun. In the case of the attack on the Kunduz hospital in Afghanistan by the United States, there was an accountability procedure, and some people were disciplined, although the criminal prosecution that could have been possible was not undertaken. And so what we found that in none of these proceedings, none of these 25 cases, was there any significant accountability. Either it wasn't started at all, or the proceedings were flawed or inadequate. So what do we need to do to end impunity? And we think that there are 4 things that have to happen. One, we need global reinforcement and expansion of norms that this is not acceptable behavior. We have to have public monitoring and reporting on incidents. And when I say public, I mean that it shouldn't be up to NGOs to go scrounge around for money so they can document what's going on. This is an international responsibility. In 2012, the World Health Assembly required WHO to develop methods to collect data and disseminate data on attacks on health workers and facilities. It's taken 5 years, and there's been incredible delays. We're hopeful that in 2017, WHO will have its methods in place. It's been an arduous, difficult, and politically fraught process. We're hoping that will happen. Third, there has to be investigations of attacks, and these are, again, an international responsibility and a domestic responsibility. Governments have to take responsibility for the conduct of their own military forces. And finally, there has to be accountability. This is really the only way we can stop the horrors that have been described this morning. Well, we thought we had a milestone a year ago. In May 2016, the UN Security Council, for the first time, adopted a resolution on attacks on healthcare. First time in its history. And it looked like a very strong resolution. It reinforced international humanitarian law, which stemmed from that first picture I showed you. And it demanded that all parties to conflicts not attack health facilities and personnel. It called on governments to develop a wide variety of measures to prevent attacks, from changing their laws, collecting data, figuring out good practices, adopting military doctrines that prevented occupation of hospitals, a whole range of activities. It called on states to conduct investigations. And if those investigations were not conducted, said the UN should order investigations. It asked the Secretary General for regular updates and a report on what's happened in 2017. Well, two things happened after that resolution in May. The slide I showed you of Aleppo in September 2016 took place. Those attacks took place 3 months after this resolution. So the minute this resolution is passed, we have systematic targeting of hospitals in Syria. That was linked to a discussion of the resolution last September at the Security Council, in which Russia's implication in those attacks was raised by other members of the Security Council. The result of that is the structure of the Security Council, with power of the permanent members, led to complete paralysis. So, since September 2016, there has been no implementation of this resolution. It is up for review at the end of next month, in May. And so there's another opportunity to make this more than a piece of paper. But as of now, as in everything involving UN business, it's really up to the power of advocacy to make a resolution have any teeth. And so there has to be some development of political will among other member states. They need to have the information, they need to have a voice, and they have to be held accountable to civil society. So, how it could be implemented? I just told you what's on this slide. So, what can the academic community do? One, as you've heard from Rahidi and Chrissy, that the research on impacts of attacks is really in its infancy. And all of those graduate students who are looking for important work to be done that's original and needed in global health, here's your topic. There is enormous work that needs to be done in understanding the impact of these attacks, because understanding impacts will increase political will. As you've heard, we need to improve data collection, And finally, we need to mobilize the voice of people who care about global health, who care about health systems, who care in their whole careers as well as their being, that this is important. Can't sit by while these intolerable acts are going. So I invite anyone, here's my plug, to get on the list for the Safeguarding Health and Conflict Coalition. I'm happy to take your name, and you'll get our email, you'll get our reports, and you can become active. It's really, unfortunately, up to us to make this change. There are people who care, but unless people are active and demand action against a recalcitrant international community and a paralyzed international community, it's not going to happen. Thank you. So we'll now open it for questions. And thank you. Yeah, there's a microphone in the front.
Thanks. This is this on? Yeah. So Jim Harrington, UNC School of Public Health, Chapel Hill. Thanks very much. Great presentations. So for our students, if you're hiring someone, what are the 2 or 3 things you want to see on their resume in their training that will attract you to them? What should we be telling our students they need to focus on in their training at the master's and doctoral level?
I can answer that. Learn Stata or learn R. And I think use your public health degree to really get quantitative skills so that you can use those, and investigative skills, I think, too. And I would personally also look for someone who's had field experience, because I wouldn't want to hire someone to work in a conflict or in a humanitarian system who has never been abroad before, really worked abroad.
Language.
From the standpoint of watch list, I mean, I think this is like the opportunity to seek qualitative skills while doing your graduate training too, because it takes both, right? And I think we all know that in terms of documenting incidents and impacts requires what we might call as a mixed methods approach, but it's really important to have those skills as a narrative storyteller as well.
And language.
Hi, my name is Naoko Kozuki. I'm the Health Research Advisor for IRC. IRC supports a lot of CHW programs, and in Yemen, South Sudan, there's a robust network of CHWs. And I was wondering if CHWs are in this conversation of safety and security. And the reason I ask is if they are experiencing similar security issues, they should be kept on the radar. And if they are not, it was mentioned for Yemen that diarrhea, respiratory infections, malnutrition are leading causes of death for children, and it's things that CHWs can do. So it may be an advocacy point that they are, not at risk of safety issues. Therefore, we can expand those networks to reach the places that are unreachable.
That's a great question, and my colleagues, I'm sure, can answer this as well. The problem about community health workers is the problem that there isn't enough attention to what are deemed the smaller events. There is, in some places, and we just didn't have time to present the data, on vaccinators, community health workers who go out with polio vaccines and other vaccines. And in Pakistan, Afghanistan, Nigeria, and some other places, there is some tracking of attacks on vaccinators, but there's not enough attention to community health workers generally, and that needs to change. Go ahead.
Well, I'd also like to thank everybody for your presentations. My name is Nathan Bertelson. I'm an internist from NYU Bellevue. I live in Istanbul, Turkey at Koç University. My question is about migrants in Turkey. We do a lot of research and training activities around the crisis in Istanbul, and as you know, the 3 million Syrians in Turkey, many of those are health workers. So I'm wondering if you can comment on activities. We're trying to harness health workers, Syrian health workers, also Afghan health workers. There's a number of Afghans in Turkey, as you know, as well. Ongoing activities with harnessing these health workers' skills or potential. If you could comment on that, please.
Well, this is a very important issue that we've been struggling with in the Syrian American diaspora, and especially with what to do with the healthcare worker who became refugees in different countries, not only in Turkey. So in Turkey, there's few types of healthcare workers, and I'm not the expert on this, but you have the healthcare workers that are working within the healthcare system in Turkey, that they are providing healthcare services to Syrian refugees in refugee camps. And I think Turkey is the only country that allowed that to happen officially. In Jordan, for example, or in Lebanon, it is not lawful for Syrian doctor or nurse to work with even Syrian refugees. It's happening, but it's under the radar. And anytime the authorities can pick up the doctors, and sometimes they send them back to Syria, force them back. And that happened in several instances, unfortunately, in some of these countries. The second part is the doctors who are in medical school, who did not finish their medical school in Syria or did not finish their training, and they're right now stuck in Turkey, and they don't know what to do. They cannot pursue their career in Turkish Turkish universities because of the language barrier and the requirement. And Turkey had made some stride in facilitating some of them, especially the ones who learn language, but this is still an issue. And if there is more opportunities for these people who are refugees in Turkey to continue their career, I think that would be something that is very appreciated. And third group is the Syrian doctors and nurses who are living in Turkey, but they work inside Syria. So they go back and forth in Syria. And I think with me is one of the experts, Dr. Abdulaziz, who's behind you. And this is his nickname. He's one of the doctors in Aleppo for a long time. He's a surgeon and professor from Aleppo University. So maybe you can add.
I'm Dr. Mahmoud Hariri Abdulaziz Sabiqan.
No.
Before this, this is
Why
my
don't you
nickname.
face the other
And
people?
I'm general surgeon from Aleppo. I've been in Aleppo last June, and I'm here presenting part of our work in Syria. If I'd like just to answer your question, we have so many things we can in Turkey help us. One of them is we have now a university inside Syria. We have faculty of medicine inside Syria. We have more than 500 students right now in preclinical phase, and those need support. Also, we started a program with help of our friends and colleagues in diaspora, like SAMS, OSM, SEMA, many of these NGOs who are helping us. We started postgrad training for residents. There is so many residents right now inside Syria did not able to continue their education, their training in different specialty. For example, we have in Syria, according to our report, 14 vascular surgeons only. They are doing more than 5% of the workload, vascular surgery. That means I'm talking about 100,000 operations per year. Take 5% of these, you know, what is the workload of those doctors? There is no vascular specialist, only few vascular surgery specialists. That means those doctors need more training, and I think Turkey can help us a lot in this regard. We can send them these doctors for maybe as a visitor doctor for a couple of months just to improve their training, and they will be back, and that would be fine. We have now 2 official bodies. The first one is University of Aleppo Committee, and we have Syrian Board of Medical Specialty, which is interested and recognized in Gaziantep as official body for post-grad training. So for any communication like this, we are happy to. And any other question about situation in Aleppo per se, I am from Aleppo, from all of these hospitals mentioned. I work in these hospitals and being targeted many times. I have a lot of experience in this regard, and many times, fortunately, still alive up till now. And I give you any. Thank you so much.
Thank you very much, Doctor.
I just may add a couple background points too about Istanbul. The Ministry of Health has opened a few dozen migrant health clinics that you may be aware of. Language barriers are huge. They don't really have any interpreters hired there, and mostly they're Turkish doctors, but they're starting to get some Arabic-speaking doctors. And we're told that they're beginning to now officially hire Syrian doctors within the Ministry of Health, but it's just unfolding now. And for the last couple of years, there have been a number of Syrian doctors allowed to practice off the radar in Istanbul, but that's been a temporary situation too, just some background. Thank you again.
Thank you.
Hi, I'm Brad Botig from the Uniformed Services University, and I was anxiously listening to hear suggestions, practical suggestions about what we're able to possibly do about this problem now of this increasing number of attacks on healthcare workers. I did see your last slide there, and it had 1 through 4. It seemed like the meat of that was the 4th one, which said to hold the perpetrators accountable. I was just wondering if you could expand on precisely how do we go about doing that? Because like a lot of the presentations were on the most recent attack in Syria. I mean, how exactly do you hold Assad accountable? Are you in favor of this Tomahawk launch? Do you suggest we do more? How do you hold the Taliban, we mentioned the Taliban attacks, accountable? How do you hold ISIS accountable? I guess that's kind of like, what is the practical solution to this? I heard mobilization and things like that, but I mean, is Assad really going to care if we as academics mobilize against him? And that's the question. Thanks.
A fair question. There are many forms of accountability, and the most narrow sense is there have to be investigations and punishments of perpetrators. And there's, in many countries, that can happen on the domestic level. They don't happen, but they could. In other cases, the only way to do it is to have it on the international level, whether it's the International Criminal Court or some other mechanism. And in fact, although referral to the International Criminal Court of Syria to the International Criminal Court has been blocked, the General Assembly has authorized investigative a new investigation mechanism for Syria. So it's not completely hopeless. But then there are other forms of accountability. There's everything from government economic sanctions to the power of pressures from public opinion. Assad is by far the worst case because he doesn't seem to be responsive to most forms of pressure. And I'm not going to issue an opinion whether you should have a missile strike. But we can't assume that every case is like Assad. For example, Saudi Arabia is bombing hospitals in Yemen. And yet, Western governments are selling arms, those very arms they're using to bomb hospitals. Well, that can change. There could be more thorough investigations of what Saudi Arabia is doing, and because it's much more susceptible to international opinion. So I don't think we should give up on accountability just because some cases are extremely hard.
Can I say something?
Sure.
I think tolerating attacks on healthcare should not be accepted. And what we're seeing in the international community, and including medical organizations, medical associations, they're not talking about it. They're not talking about it in the American College of Medicine or other global associations. And the other issue every medical organization should issue condemnation of what's happening in Syria or Yemen or other places. The second issue that even Assad is prone to pressure from the academic communities in certain Arab countries, in Iran, in Russia. And if we reach out to the medical and academic communities in these countries, they can influence their governments because the picture that they're getting through their media is very filtered, as you know. And so they're not getting and if we communicate with them as academics to academics, I think they will be able to pressure their policymakers, and that will be indirectly pressuring Assad. Everyone can be influenced by mobilizations, but we need to target the right people. If we talk about it in the American media, that will not affect Assad. If we talk about it in the Iranian media and the Russian media, that will definitely affect him.
Okay.
Good morning. My name is Dr. Roberto Nang. I'm affiliated with National Defense University and USHUS. Thank you for your dramatic and sobering presentation, Dr. Salul. I had 2 questions for you. As a former Army hospital commander in Iraq, one of the things that we had to deal with in terms of contingency was to prepare for a CBRNE issue, whether it's a chemical attack or other industrial accidents. One of the things that we needed to make sure we did was before we could treat patients to make sure that there was a good decontamination process. So my first question is, are the Syrian hospitals and clinics prepared for and are able to decontaminate properly before you take in the patients, obviously, because it would contaminate not just the facilities, but also the healthcare providers? And then the second is, with regards to the US military, we have aging medical supplies and stockpiles. is there any possibility for older stockpiles of atropine and 2-panchloride to be utilized potentially by Syrian hospitals and clinics?
These are both excellent questions, and starting from early 2013, there was a mobilization of the medical community, and Dr. Hariri knows about it. And there were actually decontamination units that were established in the city of Aleppo, which I visited. I took pictures at that time because I thought it's amazing that you have city under bombardment and siege, and they have decontamination units, which was established by local expertise. I think they read it online how to do it, and they did it. I mean, Syrians are very creative. The iPhone. So it is, but the problem, and we did a lot of training. We established actually an organization called Focus on Chemical Weapon Training for doctors inside Syria in multiple areas that not only addresses the issue of decontamination, but also the issues of antidotes, what type of classes of chemical weapons, and how do you differentiate between them, what do you do, all of these things that you need to do when you have disaster with chemical agents. And I think doctors in Syria, and I don't know if this is good or bad, are the expert in how to deal with chemical weapon in the world, because this is the country that you have chemical. There's no other country that had chemical weapon as we had in Syria. We published a report last year called A New Normal: Ongoing Chemical Weapon Attacks in Syria. We counted 161 chemical weapon attacks in Syria up to March of 2016. And until now, we have 175. This last attack was 175th attack. Most of these attacks don't show in the media because only few people die, but they are there. The problem also in Syria that we do not have enough protective gear, appropriate protective gear for medical doctors, medical staff, first responders. And that's why we have high level of medical staff affected by chemical agents. Some of them have symptoms, simple symptoms. Some of them, unfortunately, have died when they are treating the victims of chemical weapons, especially in Ghouta. There are famous cases of doctors and nurses who died. And these issues need to be always, refreshers. I'm a critical care specialist. Every year I have to do refreshers. Unless we refresh the training of the doctors and upgrade the facilities and make sure that they have proper decontamination units, they will ignore it. And at this level, before this attack, there was this sense in Syria and feeling that, why do we have to do that? Why do we have to train ourselves? It's hopeless. The regime will keep using chemical weapons. No one will pay attention to us. Why should we confirm? Why should we collect samples? So these simple things, it's very important. The advocacy and the fact that we care about them is very important, because that will make them sure that they will do this, and they will decontaminate, they will collect samples, they will confirm and document. And these are all important elements of managing chemical weapon attacks.
Marianne Hopkins, I'm a general surgeon from NYU. I've also had a 20-year affiliation with Médecins Sans Frontières, Doctors Without Borders, and your panel was just absolutely amazing. So thank you for that. And I think what you guys have done really well and really uniquely that may be able to help is point out that this is now a systematic as opposed to collateral damage or even intentional unique damage. Healthcare workers have always sort of been attacked, hospitals have been attacked, but not on this every week 4 times at the same institution. And I'm wondering, with your really amazing data collection tools, that you can now go to the US government, to the ICC. You mentioned how difficult the Security Council is now, but if you show that this has really violated the Hague and the Geneva Conventions, if that is really something. I have another question. You didn't address it. I'm not sure anyone knows, but I had heard that the laws of war for the United States were changed a year ago to accept healthcare workers as acceptable collateral damage, and journalists. And then journalists spoke up, and that changed. I don't know if it's changed. I'm assuming it has. It came out kind of under the radar. But maybe you could speak on how we can overcome these obstacles to advocacy and to bearing witness, given you have such good data and given this is a significant change that's happened in the last really 10 years.
Maybe you want to start?
I can start. In terms of how, from a watch list standpoint, and I know the Safeguarding Health and Conflict Coalition as well, we regularly communicate and present and brief member states, working groups of the Security Council, the Human Rights Council, different organizations and agencies within the UN on this issue, and make these targeted recommendations to them on what they can do to address it. I think that in concert with bringing these issues to the media and working with the media to leverage some public pressure, I mean, certainly that's our hope, can go a long way as well. But it's not, I mean, we have the access points there. It's not for lack of access points. It's for lack of action. And I think particularly with upcoming things like the briefing that is supposed to take place 1 year out of 2286, when the UN has committed to doing something, and for various reasons there's lack of follow-through for that, that's where civil society comes in to clamor very loudly in cooperation with the media and say, do what you said you were going to do.
I would certainly agree with you. The better data we have, the more influence we have. And I think an example of that is, Rohini talked about the Physicians for Human Rights data, which has become kind of the gold standard for Syria because they're very rigorous in verification. And that data is now presented by the Secretary General to the Security Council. And the Syrian government and other governments can't really deny the quality of that data. They do, of course, attack it, but it's not believed. So I think you're absolutely right. The better data we have, the more influence we'll have. On your other question, I haven't heard of any new policy about excluding protection of health care workers from protection, or some change in the interpretation of the laws of war. Actually, after the Kunduz investigation, the Department of Defense issued a 2-page statement about the protection of humanitarian personnel and the obligations of all the armed services in the United States. So I'm not aware of a reversal.
Can I say something?
Oh, go ahead.
Actually,
more question.
Related to the last question, which I forgot, about atropine and pralidoxime, I think that's welcomed. Right now we're trying to purchase large quantities from Turkey. I don't think that the regime will be using chemical weapons soon because of what happened yesterday. But I think we still have to be prepared. The more important, though, and this is always I have this idea, why not to have military hospitals that are treating the victims of bombing in Syria or the victims of chemical weapons? And we have the best hospitals in the world, United States. We have not used that to help the Syrian people. We sympathize with them, we tweet about them, we tweet about the children, but we have not done what is needed to provide life-saving measures. And we have allies in the north and in the south, Turkey and Jordan, and they are ready to help us getting military hospitals in the borders, or military hospitals, ship hospitals in the Mediterranean. And why not done that? Why we haven't done that in Syria? I do not know.
Last question.
Hi, my name is Shane Shaw. I'm a second-year Master's of Public Health student at Drexel University. And my questions for you is on the PTSD that the healthcare workers face during conflict. How are you going about addressing that? And if you can speak personally on addressing PTSD as a healthcare worker in the conflict zone.
I mean, I can speak about what we have not done because we haven't done much, really. And I think Dr. Hariri maybe has something to add, because I know that he was quite involved in how to deal with these issues when he was in Aleppo under bombardment and under siege. And they had some programs to get relief for the physicians and nurses over there. But I can tell you that these issues that we are not dealing with in the Syrian American Medical Society, even for people who are coming back from missions, we do not do briefing, we do not do counseling, we do not offer these services to our members. Many of them have these images that they brought with them for the rest of their lives. I don't know if any other academic center or NGO has better experience with this, but this is something that definitely that we need to improve on. And Dr. Hariri, I don't know if you want to add more.
In this term, we have only few things. It's underestimated, to be honest. But we are just trying to recreate ourselves as a doctors inside Syria. We have a swimming pool, doing some football games, and do something like that just to go out of the pressure of being under target. Many of our family are living outside Syria, so are moving back and forth. But in spite of this, when we were in outside Syria, we still have this feeling. To be honest, I'm here since more than 7 months right now. Believe me, up till now, when I see helicopter, I will hide. Up till now. Because I'm feeling, yesterday there is a big car, I don't know what's happened, truck close to my house. Really, I ran and jumped because I feel that she's just taking the garbage. The voice of taking the garbage, still I'm feeling that there is a bump close to me. Up till now, we need maybe some treatment, I don't know. But anyway, it is underestimated actually, and there is no real treatment on this anymore.
A few things that were done in Aleppo and other cities, besides what Dr. Hariri have mentioned, is that they established rotating vacations, forced doctors to take vacations, to leave the city, either to Turkey where it is safe, or just to change the environment. As long as you are working as a physician, and this has also happened to all physicians who are working here, you are on adrenaline and you don't know, you don't feel the impact of the exposure to very sick patients and traumatic situation. When you stop working, then that's when these things surface. It affects your emotional level, interaction with the families, your social life, your sleep life, all of these things that we are aware of. Burnt out syndrome. This is a big thing right now. We're talking about it in the critical care society. 80% of nurses have burnt out syndrome in the United States. So I think in Syria it's probably 180% of nurses and doctors. But any other people, I think.
You want to make one final comment?
Yeah, just a 10-second comment,
Okay.
if I may. First off, thanks for the answer to my previous question. That was wonderful. And then, sir, you just asked the question about why we're not putting military hospitals around the different areas there, even though that may have some medical benefit. I was going to give the quick answer that there's no political will in the U.S. Congress or the current administration for that. And the Department of Defense is dragging its feet just to respond to Ebola, let alone Syria. But thanks, appreciate it.
Well, thank you to all of you on the panel, and thanks for all of you for your attentiveness, your engagement, and I hope you'll stay involved. And if you want any of the reports that have been discussed today, just leave your name and email address, and we'll make sure you get them. Thank you again.